I want to thank everybody for coming and welcome you to our fourth Public Health and Medicine seminar series supported by the Department of Emergency Medicine and the Drexel University College of Medicine, the Center for Nonviolence and Social Justice in the Drexel University School of Public Health, and also the Pennsylvania Public Health Training Center in the Drexel University School of Public Health. Today, again, we're going to learn about the intersection about public health and medicine and how it influences our practice as well as the health of the population. Today, we're going to hear from Dr. Stephen Owens, who is a seasoned public health trained physician with expertise in global health, public health workforce recruitment, and development and minority health issues. He received his MD from East Carolina University, did his residency in family medicine at Duke University, and completed his public health degree at the Rollins School of Public Health at Emory University. Currently, Dr. Owens serves as the Director of Health Equity for the Directors of Health Promotion and Education in Washington, D.C., and in this capacity, he addresses issues of health inequalities through change in public health systems, among many other duties, and he's extremely accomplished. I want you to please join me in welcoming Dr. Stephen Owens.
Thank you. Well, before I begin, I just want to thank for the invitation to come speak and share information about the intersection between medicine and public health. And it's been a journey for me. When I was initially introduced to Drexel, I was doing international development work with USAID. Now I'm with a different agency, and I'm glad that you invited me to come back and speak again and share more information about what I'm doing now. But the topic for today is using market research technologies to design effective public health interventions. And this area is not a new area in the business sense, but it's a somewhat new approach in public health to use market research technologies to help design and be more effective at what we're doing in public health. So today for this presentation, the objectives are the, sorry about that. Oh, okay, thank you. It's better? Okay, thank you. Our learning objectives for this presentation will be to demonstrate the use of consumer market data to help leverage sparse resources and target public health policy and systems change efforts more effectively. We will also analyze selected populations and communities, and the examples that I will use will be here in Philadelphia, to understand their consumer behavior to plan public health interventions. Also, I would like to describe how you can integrate public data sources with private data sources to address consumer behaviors, improve public health initiatives and strategies. And finally, I'll recognize how understanding the social determinants of health can influence behavior and health outcomes. Last year, CDC Morbidity and Mortality Weekly Report came out in January and was a good way to kick off the year, looking at the intersection between health disparities and inequalities in health. And this report focused on social determinants of health and other health outcomes related to access and behavior. But before I get into delving more into the market research component of what we're going to talk about today, first I'd like to briefly define the social determinants of health and what we go by in public health is basically the World Health Organization of social determinants of health, which are those circumstances in which people are born, grow up, live, work, and age, as well as the systems that are put into place to deal with illness. These circumstances are in turn shaped by wider forces, which we know are economic, political, and social. So not just as a clinician looking at the patient and they come to you with a problem or you're seeing them in the emergency department, but really understand all those systems that are in place that sort of drive them to use their emergency department as their primary care source, or to look at other circumstances that community face as a whole that make outcomes worse than we would like to have. Also, in this MMW report, they looked at health access. And for health access, I used a couple of variables here in looking at insurance coverage and also visiting a doctor. But also, there was a list of morbidities related to health outcomes in this particular report. And the ones that I will focus on for this presentation are diabetes and hypertension. And finally, behavior outcomes related to cigarette smoking. Before we get to the maps and the more exciting stuff, the visual part of the presentation, I just want to briefly go of what market research can tell us. Market research can give us demographic and socioeconomic status information, as well as household characteristics at a small geographical level. Typically, public health data collected state level. We have the Pennsylvania Department of Health, the Philadelphia City Department of Health. We collect lots of data, but oftentimes that data is drilled down to the county level, but sometimes you do not get that data all the way down to the community level. And the benefit of using market research that not only you can drill down to the county level or zip code, you can also get down to the census block group level and the census tract level. So this is a new way that we're trying to implement public health interventions. And because one of the main reasons there are not lots of funds that are coming from the federal government that are going to these large state health departments and city health departments and reaching their communities. So we have to be very strategic and very deliberate in the way that we approach public health. And so what we're using now, CDC, is we're using a business approach model to address public health and better use resources. So the way market research works, basically all households in the U.S. are grouped into 1 to 66 categories. The higher you are to one, the more affluent the segments are based on purchasing behavior of the household. So this sort of gives us an ability to create a complete portrait of who our customers are, in our case, who our patients and clients are. Not only does market segments tell us where people are, it also tells us what they're like, where we can find them, and different ways that we can reach them. Traditionally, in the community level, we may do a wind zero survey, or we may just doing some type of observational survey. But this is a way that we have all this information collected from across the country, and then you can segment it down to the community level that you're interested in. So the question is, how do we translate this into public health? So based on using purchasing behavior to estimate health behaviors, we can also use that to target interventions. What marketing segments and market research data does not tell us, it will not tell you if a patient is obese. It will not tell you someone HIV positive. It will not tell you someone's hypertensive, but it will tell you the different types of products that individuals consume. And so you can stratify that data and look more at the community and different types of products and services that are being used by households. And you can just then further drill it down to the census block level. So just in a nutshell, how can we use the data? We typically know where people live. From a state and federal level, we collect information. So we have lots of information about age. We have lots of information about gender and SES. But what the business community has, it knows what type of products people buy. From the business community, we know what people are buying for smoke cessation, what type of drugs that are being purchased for hypertension, and where you may have a community where insulin may be sold at a higher level. So using business data and combining that with public health data, we can better understand where to reach people. We can know what they listen to, what they watch, and just how to reach them better. Some behaviors that I just mentioned, heavy smokers, visiting a doctor, soda consumption, those are types of things that we can find out from market research data. But also, market research data can tell us the density of fast food restaurants, parks, and other areas of interest that we may be looking at. Ideally, we would like for everyone to have access to fresh fruits and vegetables and other nutritional sources of food. But the reality is that a lot of the communities we're targeting are basically in what we would call food swamps. So you have food deserts and food swamps, and they can coexist. So just a brief review again, just looking at the level of geography. As I mentioned earlier, we have the United States, the 50 states, and then at the state level, oftentimes we have information broken up by counties. Then at the next level of geography, zip codes. Zip codes are very beneficial. It does drill down to a lower level of geography than the county, but socioeconomic status and household may vary tremendously in zip codes. Ideally, we would like to get down to the census tract level or the census block group level. Census tracts and census blocks are designed so that there is a consistent number of people from 1,200 to 8,000 people in a census tract. Ideally, it's 4,000 people, but census tracts are designed so that wherever you live in that census tract, you still have access to certain services and goods. It's not a tremendous distance. So it's better to use, if you can, drill down to the census tract level, ideally census block group level, but it's better than using zip codes, which there are lots of variances in a zip code. And so this is just a different way that we are trying to use business data and connect it with public health data. Two more terms before I get into the other part. Looking at segmentation models and business data, we look at urbanization and class and socioeconomic status of key household demographics, such as presence of children, who is in the household, is it female-led, or is it a married couple, how come? What is the age of the person who owns the house, income, but not just income, but income producing assets. These are all different types of things that we can get from market research data. And behavior we can project to a smaller geography based on the different segments, the propensity to conduct a certain behavior of interest. So because we are looking at a smaller group, a smaller area, and the population and the households within that census tract or census block group are very similar, we can then extrapolate different behaviors that are common in that particular group. One other term I would like to share with you is the Market Potential Index. And the Market Potential Index is an index that's used for segment composition of geographies, and is also used to estimate customer potential based on segment penetration. So looking at a certain good or product or service, and based on a person's lifestyle and where the person is in this class of lifestyle, where we group someone into the younger age group, the mature age, and then the family age. And within those different groups, we also have segmentations from 1 to 66, 1 being the most affluent. So based on all this index and the propensity for a potential group to use or access a certain product, we could then draw certain conclusions of how, if we market a certain product or certain interventions, how it would be received in that community. A market potential index that is greater than 100 indicates that the target group of geography is more likely to use a product or service than in the areas of interest than others. If the market potential index is less than 100, that tells us that the target group is less likely to use the product or service than others in the area. And if it's equal to 100, it tells us that they're just as likely to use the product or service. So based on the different indicators that was listed in the MMW report that I mentioned earlier, we looked at having medical insurance by census tract in Philadelphia. And from a business model, you can see the red area, the market potential index is less than 100. So if an insurance company were looking for people to insure, that's what we would do. But if we're in a public health view, we know that this area where people are less likely to have insurance, so we may want to increase services there. And the map is broken up by census tracts. Then I relayered this and looked at visiting a general or family physician in the past year. Using market research data, all specialties are listed, but just to get a general understanding for this presentation, I used the family doctor as a model. Although there's emergency physicians that are in the database, general internal medicine, and all the different specialties that are in medicine. But just for this presentation, we're looking at one, the presence of insurance, and two, if they visit a doctor. So next, we did a shape file, and so this is the part of the metro area, Philadelphia, that we want to focus on. So this area is less likely to have medical insurance, and least likely to also have visited a family doctor within the past year. Doing a further analysis of these two groups, looking at most likely to visit a doctor and least likely to visit a doctor, we see that in census tracts where people are most likely to visit a doctor, that the income is twice as high in those tracts than people who are least likely to visit a doctor. And also, as we drill down to per capita income, it remains 1.9 times greater in tracts that have access or visit a doctor versus those tracts that do not have insurance and do not visit a doctor. Also, the other social determinant of health that was highlighted in the MMWR was education, less than a high school diploma. And we can also see in those tracts that are least likely to visit a doctor that nearly 1/4 of the people in that particular area do not have less than a high school diploma, versus those tracts that are most likely to visit a doctor where the majority of them have had some college or are college graduates. And then further looking at the composition of race in this particular area of tracts that are least likely to visit a doctor versus most likely to visit a doctor, we see that the areas that are most likely to visit a doctor are primarily white, and least likely to visit a doctor are African American or Black identified. And then we talked about income producing access and ability to buy goods, and we use vehicles as one of those indicators. And you can see that although there's a good public transportation system here in Philadelphia, that census tracts where people are least likely to visit a doctor, over half do not own a vehicle, versus those who are most likely to visit a doctor, nearly 86% of households own a vehicle. And so another indicator is looking at how people get to work. And we can see that in tracts where people are least likely to visit a doctor, it's not a surprise that they do use public transportation, versus those who do have access to a car, they either drive alone or carpool. And then further drilling down, looking at poverty level and the other indicator, social determinant of health, that was highlighted in the presentation, we can see that tracts that are least likely to visit a doctor in Philadelphia, that is 33% poverty level, versus tracts that are most likely to visit doctors only 6.4%. And for the city in general, the poverty rate is around 19%. So just a summary, and I didn't go through all the variables of that we ran, but looking at tracts where people are most likely to visit a doctor versus those tracts where people are least likely to visit a doctor, we see that there's higher poverty, there's less education, predominantly African American, the household income and per capita income are less, and also a slide I did not show that households consist of mostly female head of household, without children 24%, with children 24%, and some married couples 22%, and then access to a car only 47%. So now looking at Philadelphia and looking at families living below poverty, we can I highlighted where the College of Medicine is located, and then trying to look at where are people who are families that are below poverty. And so you can see where the areas that are brown, those are have the higher rates of poverty in the city. And it's not too far from where we are. And then next, what we did, we looked at the composition of census tracts that are less likely to visit a doctor. So keeping that shape file in mind that I showed earlier during the presentation. And then looking at, we know that African Americans are the predominant ethnic group in that tract. And so this tract, this particular map layers poverty and where the presence of African American population in Philadelphia. And so you can see there's lots of overlap between poverty and the African American population in Philadelphia. But the school is highlighted in the map, and you can see around the school there is one of the less poverty. But as we drill down, we will see more. And then next, we talked about access to care and looking at where are hospitals or where the population that we're talking about usually access the healthcare system. Oftentimes it's through the emergency room. So doing, looking at the levels of poverty again in Philadelphia, and then looking at where hospitals are, we see that they're located, their location throughout the city. But then looking further at primary care offices, we see that they're scattered all over the city. So this map is very confusing. So let's drill down closer to where we are, looking at the census tracts where there are high poverty rates. And we can see very close to the School of Medicine that there is a high rate of poverty in this area here. But as we then look at the hospitals, and, look, and then next, look at the primary care offices, you can see that they're primarily located in area with the exclusion of this area where it's very close to a very high poverty area, but they tend to be more so in tracts where there is not large poverty. And we remember there's hospitals over in this area too. And so just doing a ring study and just looking at the distance where people have to travel to get to primary care offices. So where the higher poverty that is located north, we see from a ring study from a mile, 1.5 miles from this area that someone would have to reach to get to the emergency room or a hospital. So now I'm going to transition into using some state data, public data that everyone have access to from our friends at the Pennsylvania Department of Health, and looking at one of the health morbidity outcomes that were highlighted in the MMWR, and we see diabetes, a trend that is increasing in Pennsylvania from 2004 to 2010. And then when we look at diabetes based on household income, we see that the less the income, the higher the rate of diabetes, where the state rate is 10.3. Next, looking at emergency room data visits for Hanhnemann University Hospital, we see that majority of the individuals who come to the emergency room are Black. And we also know that this aligns with the high state rate of diabetes in Pennsylvania. Next, we looked at the age of people who visit the hospital for hyperglycemia or diabetes. And then we want to focus on this area. And then look closer at the age of people who present to the hospital. So this is an opportunity for interventions. People who present to Hanhnemann Hospital for visits for hyperglycemia and that requires an emergency room visit. We see that they tend to be to present earlier if they're black versus other, which we weren't quite sure what that particular group category is, that group was indicated on. But you also see that there's also, looking here, that blacks tend to have to visit sooner. And from this chart, it's they peak at around age 60, where you have the most visits. Now, with diabetes, we always tell our patients to try to consume mostly fresh fruits and vegetables and limit the amount of sugar in their diet, refined sugar in their diet. But looking again at market potential index, so this tells us where people are least likely to consume fresh fruits and vegetables versus the part of the graph where you remember earlier, those populations that are most likely to have insurance, most likely to visit a primary care physician, there are more north. But this part of the city, although we have lots of programs in Philadelphia that we researched where you can use an EBT card at fruits, at farmers market, but still the market potential index for people who are least likely to consume fresh fruits and vegetables are in the poorest parts of the city. Next, looking at heavy consumption of cola, we could, from a business standpoint, this is where we will want to market cola, but from a public health standpoint, this population here by census tracts are the least are the most likely to consume heavy cola, and extrapolating that to the population that are visiting for hyperglycemia and uncontrolled diabetes, we may want to focus our interventions in this part of the city. So the next geography, I looked at access to fresh fruits and vegetables and trying to give some idea of where food deserts are located in Philadelphia. And as you can see from the graph, there are a higher number of full service or large grocery stores that are away, somewhat away from the poorest parts of the city. But then the medium grocery stores may have fresh fruits and vegetables on their shelves, but then you look at where they're located, and but next looking at small grocery store where you may have less choices, and they become more centered in the more poor part of the city. But let's take a step back and look at around where we are located, large grocery stores. And there's one here, but it's in a more affluent part of the city. And then looking at medium grocery stores, still mostly, you know, higher SES, less impoverished areas, and small grocery stores. Now you start to see them in the poverty area, and that's convenience stores. And then also a ring stay. So just looking at the disparity, and your patients come and you like consume fresh fruits and vegetables, but the largest, the full service grocery store in this area around the School of Medicine, we can see that someone here is approximately um, 3/4 of a mile or a half a mile to 3/4 of a mile. So we really have to understand some of the challenges that our patients have when we make recommendations for them to consume more fresh fruits and vegetables or limit their amounts of soda, that those are the things or goods that are available to them. We have to come up with different strategies to approach this. And so this is another look at convenience center. The other behavior role outcome we looked at was cigarette smoking. And you can see the prevalence of cigarette smoking in Philadelphia, that it is going down since 1995. But again, looking at the rate of cigarettes, the prevalence of cigarette smoking for Pennsylvania, we see that the poorer the families, the more smoking, with the state rate of 18.4%. Next, looking at smoking by household, we see that mostly African American, and the rate still 18.4%. But African Americans in Pennsylvania tend to um, have higher smoking. The smoking tend to be higher. And now let's look at visits to Heinemann University Hospital for COPD. We know that from 80 to 90% of COPD is caused by long-term smoking. And then again, let's look at the graph so we can look at it a little closer. And then you can see that African Americans are showing up sooner. So you really need to maybe consider targeting your programs for different behavior outcomes, behavior related to cigarette smoking and prevention of COPD. Target African Americans at a much younger age. And then there's the next highest was the Arabic population. And then looking at cigarette sales, we can see that most likely to purchase cigarettes are located in the high poverty areas of Philadelphia versus the least likely to smoke 7 packs of cigarettes per week, or with an average of probably a pack per day. But then looking at cigarette sales, but in the higher income area, you can see that more expenditures on cigarette sale. But if you look, keep in mind that this is the area that probably has lower per capita income and lower household income, but there is a high rate of cigarette purchases, sales, expenditures um, for these families that live in this area. Then just drilling down a little closer, looking at Philadelphia or around the area for the hospital where the high cigarette sales. Next, looking at another leading cause or people present to the emergency room, we see that for myocardial infarction, that the rate tends to be higher, less income, higher myocardial infarction rate by household. And then next, looking at Pennsylvania, although blacks are lower here from Hanhnemann University Hospital for different cardiovascular related events, we see that the majority of the people who visit the hospital tend to be African American. But then we always encourage our patients, an aspirin a day um, for heart attack prevention. And so you can see where the high poverty rate, this is least likely to purchase aspirin for relief related to heart attack prevention. So areas where you may want to focus your interventions, and this is something simple that we can do. And then this is no surprise, the ones that are most likely to have insurance are you have a higher most likelihood to visit a cardiologist in the past year. But then we always encourage our patients to exercise, but trying to figure out what's going on in the communities, these census block here where it's dark green, these individuals are least likely to exercise. And so thinking about not just encourage your patients to monitor their BMI and lose weight and exercise most days per week, we really have to figure out what's going on in these communities, what is impeding these healthy habits that as physicians we try to get our patients to have. And then looking at facilities where there are health clubs, and we probably wouldn't expect um, someone that may have challenges or not disposable income to invest in a health club membership. But you can see that they are located all around the city. But as we drill down to where we are, they again tend to be in the more affluent areas.
When you're getting exercise, you're talking about expenditures on exercise as opposed to getting exercise?
Yes, yes,
All
expend.
expenditures. If you go to a place where you pay money to exercise, you show up as exercise. If you're not paying money, if you're going out to a free public court and playing basketball all day, you won't show up as getting any exercise.
Right, but right, and we can look at parks also and access to parks um, and free sports facilities. But as you stated, yes, that the expenditures, this is expenditures of on sports clubs. This is this is not Griffith's data. The previous slides were, so it is behavior on the Griffith's data. But this is market research, the expenditures. And then another variable we just looked at, likelihood of buying fast food, where you see, which was a surprise that in the suburbs, lots of fast food being purchased versus in this area. And then we wanted to look at different types of fast food, so we looked at hamburger and still a higher proportion of expenditures are in this area where people are most likely to visit a doctor and have insurance.
So you're saying they eat that in the center city in that chart, but that's not what we've seen before. We're getting a funny chart here. We're told that they don't eat fresh fruits and vegetables. Now we're told that they don't eat hamburgers.
They may eat Chinese food.
What?
They may eat Chinese, the other types of fast food establishments. We just use hamburgers in this graph. But we're not saying, we know they're eating something. But this is just an example of using fast food hamburger. The major businesses like McDonald's, Wendy's. But we know this is where they're showing up the higher expenditures are.
Right. So this is not telling us what they're eating.
It tells where they spend the money.
Uh,
They're not telling us exactly what they're eating, correct?
Is this telling us where they're spending their money? Or is this telling us where the money is being spent? Because the establishments that are taking in cash are located, we've seen, outside of the central zone. Is this where money is being spent, or is this where these people are spending their money? Is it focused on the people and what they're spending, or is this focused on the institutions that collect money in and what's being bought?
It's focused on the institutions that are collecting money on expenditures.
So we have to watch out and not infer something from this about the people in the poor zone.
Exactly right. Exactly right. You won't use this data alone. And as I get further into the presentation, that's one of the cautionary notes, not just to use this data to stand alone. You have a better idea of what's going on in the communities and what's going on with your patients, the different challenges that they present with. So this is just to complement information that you may already know. Okay. And also going back to looking at families below poverty and fast food, the location of fast food burgers, fast food burgers restaurant. And these are some that you may be familiar with some of these places that are close by here. But getting back to some of the solutions, we want to encourage active living and healthy eating in the populations that we serve, regardless of if they're poor or high SES. And we want to increase the availability of fresh fruits and vegetables in areas where they may not have access. And also we want to eliminate food deserts and, just as a point, I think eliminate food swamps. We can look at food procurement policies to increase low sodium options. School systems, they purchase lots of food. Work with school systems, those vendors, to see if you can be able to influence the types of food that are being purchased for children that are attending school. And then, as I mentioned, come up with incentives for new grocery stores to locate in the areas where there may be populations that are impoverished. Some of the strategies that we can look at how to reach people in Philadelphia who are least likely to visit a doctor. Um, and one of the slides that I showed earlier is so that a lot of them are female head of household with children. So some of the things that they are most likely to enjoy, they may buy toys for the children or soccer games. These are type activities, maybe baseball. These are types of activities. Um, Karate, buy tricycles. Things that activity they least likely to enjoy or participate in are listed here. Belong to a country club, buy a treadmill. Looking at people, the types of radio stations. These are types, not specific radio stations um, that they're most likely to listen to and least likely to listen to. Different types of TV stations, very um, maybe ethnic centric types of TV stations, but looking at different sports and leisure activities that they're most likely to participate in, ones that they're least likely to participate in for people who smoke. Radio stations for the hours of times that you may be able to reach them. Types of radio station that they are least likely to listen to. Other types of TV stations they are most likely to listen to for people that they're smoking in the household. And then, as far as exercise, what different types of sports and leisure activities they're most likely to enjoy, and most least likely to enjoy, and most likely to enjoy. Types of exercise activities, radio stations that they listen most likely to listen to, least likely to listen to. So as you look at the type of behavior that um, you have identified that you want to target, user market research data can tell you different types of activities that the population is most likely and least likely to participate in. So it's to complement some of the things that you know that are available for populations here in Philadelphia. And then just a review that these are some of the uses of market research data. It tells us about behavior, alcohol sales, uses, purchases, over-the-counter drugs purchases, and some prescription drugs purchases. It tells us the area of interest that we're looking for our interventions, and also the different geographic areas, consumer behavior, business locations, and populations, demographics, and density. Some of the projects that the Pennsylvania Department of Health is working on using market research data. They are developing health profiles for all the communities in Pennsylvania. Also, they use the data to identify where they should target their resources post the floodings that happened back in September of last year. And also, they're working with the University of Pennsylvania to determine the geographic distribution of television viewing and disease in Pennsylvania. So this is to complement data. It's not used to be as standalone data. And so these are some of the cautionary notes that I want to get to, that the data is this based on national trends, and it's projected down to the geography of interest in the population and size. You have a better understanding or idea of what's going on in your communities. This data is intended to be complemented, not to be used as a standalone data, but it's meant to supplement other data, things that you know. Just a few closing thoughts. I would like for you, hopefully, to think beyond health disparities, but not to overlook those social determinants of health that I highlighted, but other social determinants that I did not cover. Understand that health inequities are all around us, and have just be encouraged and have the courage to challenge how systems are in place, and challenge the public health programs and really sort of break away from the traditional things that we do, going out doing a community needs assessment, doing an intervention, doing all the academic type things the right way, but not having a program, a real impact on the communities that we're trying to serve. Thank you.
market research data has been kind of expensive and unable to get. Has that changed at all?
No, it has not changed. Um, But what we're doing, working with state health departments, so there are people at state health departments that can work with universities or communities to do special projects. But no, it has not changed. It's very expensive.
Just one other housekeeping thing. As you leave, please be sure to turn in your evaluations to Elliot outside. We can gather all your thoughts. Any other questions? Again, I want to thank everyone for coming out. I want to thank Dr. Owens again. And we look forward to this again in April. So bring your thoughts, bring your mind.